In its fifth edition, the Diagnostic and Statistical Manual of Mental Disorders deliberately omitted a term that had dominated clinical vocabulary for decades: drug addiction. Instead, the manual adopted the classification substance use disorder. This shift was required to capture a clinical continuum. A patient's presentation can range from a mild behavioral impairment to a severe, chronically relapsing compulsion to seek out a chemical. To map this continuum, clinicians look at a few baseline criteria. The first is substance intoxication, an immediate, observable physiological and behavioral change directly following the ingestion of a material. On the end of that spectrum is substance withdrawal. This is the specific physiological distress, cramps, tremors, or severe anxiety that occurs when the chemical is abruptly reduced or stopped entirely. Bridging the two is tolerance, the biological reality that a user must ingest an escalating dosage of the substance just to achieve the original chemical baseline. When you chart intoxication, tolerance, and withdrawal together, a clear pattern emerges. Substance use disorder is a multi-layered system failure. To understand how it operates, we have to map it across three intersecting layers: the biological, the psychological, and the sociocultural. Mapping the disorder in this way reveals it as a cascading failure across a patient's internal and external systems. Let's start at the foundational layer, the biological. Different substance classes dictate different pathologies based on specific receptor-level interactions. When consumed, a depressant like ethyl alcohol binds directly to GABA receptors in the brain, inhibiting central nervous system activity and slowing down the body's reaction times. This graph charts alcohol absorption rates, illustrating how physiological variables dictate the severity of these effects. The concentration of ethyl alcohol in the body fluctuates based on recent fat and carbohydrate intake, baseline body mass, and the different water ratios dictated by gender. Opioids act as another powerful class of depressants, carrying a peculiar historical edge case. Following the Civil War, many veterans developed a tolerance to morphine, that it became known as soldier's disease. In response, the German chemical company Bayer synthesized a new cough suppressant in 1898 called heroin, marketed it as a non-addictive alternative to morphine. Its high abuse potential triggered a sweeping congressional ban by 1917. Stimulants provide a direct contrast. These substances increase the volume of dopamine, norepinephrine, and serotonin moving through the synaptic gap, triggering intense euphoria. The abuse potential of a stimulant is heavily influenced by its pharmacokinetics, specifically how fast it reaches the brain. Cocaine, extracted from the South American coca plant, can be inhaled as a powder, but when processed into a freebase form and smoked, its brain absorption rate reaches 10 to 15 seconds. Other synthetic stimulants leave severe physical markers. Methamphetamine restricts blood flow to the point where users frequently develop extensive facial lesions and extreme dental decay as the physical body deteriorates. Legally unregulated stimulants carry biological risk. Caffeine is the most widely consumed substance in the world. Recently, emergency room visits for caffeine intoxication have spiked, driven largely by 30% of adolescents consuming energy drinks that pack double the dosage of standard caffeinated beverages. The third major category includes hallucinogens and cannabis. These compounds distort sensory perception. Interestingly, while users build a tolerance requiring larger doses, classic hallucinogens generally lack the physiological addictive properties seen in depressants and stimulants. Cannabis produces its effects when THC binds to specific cannabinoid receptors in the brain. For most, this induces relaxation. However, introducing THC during critical periods of adolescent brain development carries steep risk factors, including cognitive interference and, in rare instances, the triggering of psychotic symptoms. The risk increases when these classes are mixed. Combining multiple depressants leads to acute respiratory failure. Crossing a depressant with a stimulant forces the body into a state where it can no longer maintain internal homeostasis. A patient's clinical presentation, the severity of their crash, and the exact nature of their withdrawal are dictated by the specific receptor-level pharmacological interaction of their chosen substance. Looking at this data from the Substance Abuse and Mental Health Services Administration, we can see the distribution of this biological vulnerability. Native Americans currently hold the highest prevalence rate for substance abuse at nearly 22%. The demographic splits vary by the substance. Men outnumber women 2-to-1 in alcohol abuse. However, for synthetic stimulants like methamphetamine, the usage is split equally across genders. We also see an economic skew in the data. Because cocaine is expensive to produce and procure, its highest consumption rates cluster in more affluent suburban neighborhoods. Substance use disorder rarely occurs in isolation. It carries a remarkably high rate of comorbidity, first with itself, as individuals frequently engage in polysubstance abuse. Second, it is highly comorbid with other psychiatric conditions. For many patients, the disorder develops as a form of self-medication, an attempt to chemically suppress underlying anxiety, affective disorders, or PTSD. The data proves that addiction does not operate in a vacuum. It is statistically intertwined with pre-existing demographic vulnerabilities and underlying psychological distress. To understand how a user gets trapped in this pathology, we look at etiology, the exact causes of the disorder. Twin studies reveal a 50 to 60% heritability risk for alcohol abuse. However, this genetic vulnerability remains latent unless it is activated. An individual with a high heritability risk will not develop an abuse disorder without the specific environmental exposure required to initiate the cycle. When that exposure happens, the chemical hijacks a specific piece of neurobiological hardware, the mesocortical limbic dopamine system, the brain's primary reward center. This biological hijacking is reinforced by the psychological layer through cognitive expectancy. If an individual anticipates a positive outcome, like a reduction in tension or enhanced social pleasure, that expectation actively drives their drug-seeking behavior. Cognitive models show that negative expectations, knowing the drug will cause a painful crash or ruin a career, are statistically weaker deterrents compared to the psychological pull of those anticipated positive effects. This creates a cycle governed by operant conditioning. The behavioral engine begins with positive reinforcement, where the chemical high physically rewards the user for ingesting the substance. The loop tightens through negative reinforcement. First, the substance is used to temporarily remove the user from negative environmental stimuli, whether that is physical pain, trauma, or daily stress. Then, the second half of negative reinforcement locks them in. Once physical dependence sets in, the user must ingest the substance simply to escape the agonizing cramps, tremors, and nausea of chemical withdrawal. Finally, sociocultural factors normalize this loop. Peer pressure, a family history of accepting drug use, and the correlation between financial instability and SUD prevalence all act as environmental accelerants. Addiction is maintained by a self-reinforcing cycle. Biological cravings are amplified by behavioral conditioning and left unchecked by environmental stressors. Because the pathology exists across multiple layers, clinical interventions must be precisely targeted. At the biological level, patients undergo medical detoxification to safely manage withdrawal, though some require the introduction of agonist drugs. Methadone is a common agonist. By reacting to the exact same neurotransmitter receptors as heroin, it stabilizes the patient. The controversy lies in its mechanism. It replaces a volatile, illicit addiction with a highly regulated medical dependency. Antagonist drugs take the opposite approach. Medications like naloxone for opioids or disulfiram for alcohol actively block the targeted receptors, neutralizing the substance's euphoric effects or inducing severe nausea if the chemical is ingested. These treatments carry acute medical risk. Administering an antagonist strips the receptors so violently it can send a physically dependent patient into immediate and potentially fatal withdrawal if not strictly supervised. Moving up to the psychological layer, behavioral therapies attempt to reverse engineer the patient's operant conditioning. Contingency management is a framework that directly rewards clinical adherence and negative drug tests with tangible vouchers or prizes. This is often paired with relapse prevention training, a cognitive behavioral approach where clinicians guide patients to identify their specific intrapersonal triggers. Patients practice cognitive restructuring, learning to short-circuit their automatic responses during high-risk scenarios. At the sociocultural level, interventions like the 12-step model used by Alcoholics Anonymous rely on community reinforcement. These programs foster spiritual development and operate on the strict requirement of complete abstinence. For cases requiring total environmental resets, residential treatment centers completely remove a patient from their triggers. While the clinical efficacy of isolating the patient in a drug-free community is high, the financial cost creates an accessibility barrier for the general public. Treatment is never one-size-fits-all. Targeted interventions must match the specific biological, behavioral, or environmental failure points of the individual's disorder to achieve lasting efficacy. This model maps failure points to clinical interventions. However, treating a single variable risks relapse. Biological detox fails without cognitive training for psychological triggers. Behavioral incentives fail if patients return to a sociocultural environment of active users and financial stress. A successful clinical treatment requires mapping the substance pharmacokinetics against the genetic and environmental baseline of the patient. Substance use disorder resists simple answers. Surviving it demands multimodal clinical frameworks built to repair a deeply complex human system.